So 80% of people who need palliative, only 14% of people who need palliative will receive palliative. 83% of the world's population have lack access. Is that not shock? Does that shock you, or does that relate to your practice? 80% of them have a lack of access to, and 98% of children needing palliative live in low and middle income countries. So there are disparities in care, as in all healthcare, high income countries and low. So some of the reasons for so much the increase and the people not receiving palliative care in the world is that we are living so long nowadays. And I looked up the life expectancy from 90 something in India up until 2019. And it's just shot up. Your graph has just shot up. So yeah, live much longer. But when the WHO was started in 1948, so about 75 years later, global life expectancy, that's all kinds of countries, global life expectancy was 25 years less than it is today. 5 years, that's incredible. So making good. And I believe the first person has already been in the world. So there's an increase in the elderly. Of course, there's an increase in age-related. But in this 21st century, much more from acute. So we used to die of heart attacks, and now we live with heart failure. We had strokes and we died, and now we live with vascular. But it's life as well. So diabetic death is now diabetic life, 75 years, and HIV death, much more recent, is now turned to. There are many, many, many more people who have a disease with no cure and the need palliative. We do know, we've talked about it a bit, but the social determinants of. But a child born in a low-income country, an average life expectancy of compared to 80 years in a high income. And this gap, this 70-year gap, has not shifted in the last 20 years. That is a disgrace. I want to do. So this is the theory. We're focusing, as we've said, everybody has said in our introductory nurses have said, we focus on improving quality of life. We affirm life. We see death as a natural process, and that's personal. Any diagnosis, and cardiovascular is the latest palliative. So you can have palliative care, and you can always have therapy. But patient and family's preference always individualized and personalized care. So when do we need palliative care? We need palliative as early as possible. And we're talking about cancer at this, that's at the diagnosis of cancer. And I'm sure in your experience, as in our experience, palliative care comes far too long after the diagnosis, and often that's far too late. Already said, if we put good palliative care in at the beginning, after diagnosis, we can make a difference not only to the quality of the patient, but to the quantity. And all this early work that's just come out in the last decade has changed the outlook in the UK, and we now have enhanced supportive care. So these data and the evidence base for early palliative care has switched now to enhanced supportive care. And enhanced supportive care promotes the early implementation of supportive within cancer, multi-professional deliver the model, and it's usually clinical nurse specialists who lead the enhanced support. And one of the references I showed you at the beginning, so that you have enhanced supportive people who have with cancer who have had enhanced supportive care, and normally led by nurses, have lived longer. And that's an ongoing patient care. And it's but in the US, even BASH has shown that if you monitor people on mobile phones and ask them for and respond to what they're telling by phone, also increase the level by good hands. But there are many, many challenges, aren't there, palliative, and many challenges. Got a billion people, the population density, there is poverty, and no doubt about that. It's wonderful to have geographical diversity, so it brings richness in with it, but it's different in different. And there are still restrictive policies. Talking yesterday about the restrictive policies in Punjab regarding pain relief with the workforce. Our development and training need more development and training in palliative care, and we'll talk about that later. But really, there is an Indian national health policy, and the limited national palliative care policy, and a lack of institutional interest in palliative, not at this. You have a fellowship, you were telling us, in palliative. So we need to extend that to the community nurses. We've got some health nurses, so you are a beacon of light in palliative. So I'm saying you should be very, very proud of what you've done. Another challenge is health literacy of the population. And that shows for palliative care outcomes, if there's limited literacy, limited health literacy, there is less access. The people with cancer have less access and use palliative, and all the reference, all evidence tend to have much poorer pain management, and they have the inability to sign advanced direct attempt. So this is that's the same as us, and you find that people who are have low health literacy, and this is our job as nurses. I've already said communications, coding, education, and giving that information in clear language helps all these disparities. So we've seen all the challenges. The challenges are massive, and now we are looking at some. The solutions, according to the WHO, and I've transferred that into India, are to revise laws and process. So this is at government level, and we had our special guest from the Ministry of Health. Do not be afraid to managers and speak to the Minister of Health. So it's about leadership and doing something about it. You can speak, you can influence. If you find something wrong in care or something that you want to change, you can get there. So you have approachable. So the Indian National Health Policy and other international bodies endorse palliative care as an essential healthcare service. That's in it. So we have to include palliative care in the training of healthcare workers. We've shown that we've already heard that you're a beacon of light in that as well, but there is much more work to do. So I talked about the diversity and the culture in different parts of it. And we know that Northeast India has very poor or no palliative. South is very, very good. Kerala is better and here. But there are some papers and some evidence that show they can develop a successful model providing palliative care to rural areas of North India. And that was about mobile community team support of, and that was all done by nurses North India. So you'll have heard of Can Support, the charity that is a model for home-based palliative care in India. So you definitely have some solutions, big challenges. One of the solutions is how to identify. So we said that we have to identify the need and the patient's need for palliative care as early as possible after diagnosis. And we have what's called a SPIC tool. It's a clinical tool that is used by healthcare professionals in many countries. And they have one, you're not a low resource country, but LIS means low income setting. And this is about finding out who needs palliative. This is really about finding out who needs palliative. So the SPIC low income setting tool seems to, it started, the first one started off in Nepal, which is not a million miles away from here. It hasn't been in India yet, but you could use this tool because in Thailand, they've found that this tool in low income works very well. And it's all in one page and it's really good. And that shows when to start, how to identify people in need of palliative. Remember, in the world, we've got 40 million. This is just a starter in your own state. As you said, palliative care is for everybody. It's everybody. We're talking to the students yesterday, and of course, there's people in hospital, their fourth year experience who are in need of palliative care. We start in first year advanced, but there are not enough healthcare providers in college palliative care workforce plans, and especially in. So education, again, like communication, they're the golden key. So in America, they have a model very much like this university. Just to train the tutors in palliative care, and the tutors in palliative care so can train the other nurses, filtered, not just palliative. And this is work done by Laura Fenimore. So she's the immediate past president of the Oncology Nursing Society, and they have 40,000 members or something in the United States. Did this with Betty Farrell that we about before. Betty Farrell is a goddess of palliative care in life and has the LNEC course. Yes, have you? Hands up if you've done the LNEC course. There you are. So they have an LNEC India course up as well, and it's all about palliative and so this training, the tutors train their doctoral have to be that teaching many disciplines about palliative, and they found it was a very successful model, and they're going to. And I think everybody, I think you're ahead of the game, ahead of the ONS, ahead of the. And I said we'll talk a bit about volunteers. The volunteers are anybody that wants to efforts decrease the suffering of people living with chronic, and they have to be structured. Hands up who has palliative. To have volunteers. Oh yeah, so you've been in others. There you are. and in Northeast, yeah, I know the friend from Northeast. So structured training of volunteers, and the volunteers can provide regular and continuous emotional support for the patient and family. They give social support, wound care. So a lot of nurses here with palliative care and do a lot of wound care, and they're trained volunteers at. So it spreads the idea of palliative care, and it helps the organization. The one big symptom that the WHO mentions is pain. But Dame Cecily Saunders, the founder of modern hospice, finds total pain as the suffering that encompasses all of the person's physical, psychological, social, spiritual, and practical. So we're not just talking about, we always must remember in our head, pain is not just, but talking about physical, talking about cancer pain, far too simplistic, tend to associate advanced. But cancer-related can be associated with malignant disease or their treatment. So people with cancer also have other conditions, comorbidities, and we saw the rise in the elderly population, comorbidity. It's best to think of pain in people with cancer. So the WHO ladder you'll be familiar with started in 1906, and this is the 86 model. Oral morphine was the drug of choice by the mouth. It was given by the clock and by the ladder, and it was very, very restrictive. So they've adapted it over the years, 2022. And the solutions for the 21st century are the attention to cancer in all stages, after surgery, chemotherapy, during chemotherapy, into survivorship, and end life. So not just about pain. And again, taking the whole person, and taking into account their age of aims of cancer. So we're into multimodal analgesia, and yesterday we were talking about the drugs that are available in the PGIMER, and the opioids are restricted. But smart targeted pain management, maximum efficacy, and minimum adverse events. And we have our specialists in pain management in the UK to refer to. For persistent pain, it's wrong to think of pain as only an end of life issue. Pain is present at all stages of cancer. Have to remember about breakthrough pain. Breakthrough pain is episodic pain, and the sleep is disrupted, emotional health, personal relationship. So it's more like the Cecily Saunders model here, or what she says is pain. Ability to perform activities is reduced. Concentration, so cognitive ability and thought is reduced. And work performance, active, all being breakthrough. So definitely risk assess for addiction. We're talking about addiction, and don't confuse it. Don't confuse addiction dependence on opioids. So you have to check patient risk factors. Have they had previous addictive personalities, alcohol, drugs, and gambling? And if a possible risk of addiction is detected, optimize the background. You extended opioid formulations are licensed, and ensure maximum number of rescues. There are many on-drug methods. So 21st century solution, we talk about a platform. So it's anti-cancer treatments, it's surgery, it's analgesics, and we call it a trolley. This paper calls it a pyramid or a trolley. We have many answers to pain relief, and it's not just for nursing and other psychology. Along the cancer continuum, we're all going to die. Put end of life action. And why do we need to recognize? So this isn't the SPIC tool. SPIC identify people in need of palliative. This is the end of. It's so important early because we want to make shared decision making with cancer and their families. Want to take away, prevent unnecessary intervention. That could be surgery if the patient doesn't want surgery. It could be other medications that are causing concern, like diabetic medication, like other pain control, like anticoagulation or something. So we have to help to ensure that the dying person wishes. So it just reduces. So good communication helps a dying person's improves end of life and improves bereavement experience after the. But why do we find it so difficult to recognize that a patient is even for the most experienced, like Isabel was saying yesterday, communication can be difficult, and well, for sexuality to take some years to be confident in. But we usually want to save lives, and actually we want to make the quality of this dying process best. And so it's do we keep on going with treatments? Is there a pressure to keep on going with? We have to think of the patient and the family and society. It's like sexuality, a tendency in the UK to shy away from dying, and there is sometimes an dying, no, lack of experience of nurses, or lack of or inadequate communication. So we have in the UK advanced communication for the whole team, and not just the palliative. We saw that the surgeons were involved in in the pain control of the patient, and the whole team, palliative care team, and so have advanced communication skills training for all these disciplines, and for it used to be mandatory, and then we ran out of money, and you have it in your course, advanced and how to enter the conversation, start the conversation, but most importantly, how to get family with. What signs are there to help us recognize somebody is entering the last day of life? Seen it all yourself. Tiredness, breathlessness, urine. So the person may tell you that they're dying, and that's when the end of life comes into. Earlier the better about communication about dying and end of life. It's important to ascertain the patient's level of involvement in decisions, as we heard just, and it's more likely to lead to advanced care planning discussions. Patients start early with what's important to you, what are your concerns, what are your questions, and then we can there is an escalation of care for the patient to end of life and the DNR discussion. So it's important to do this while patients have capacity, and not everybody at end of life, as you know, capacity. So likewise, documentation. document everything you're doing, not just at end of life, but all the way through, and share this documentation. Most importantly, so in the UK, we tend to have patient-held notes at home, held notes, and they bring these notes into, and these must be reviewed frequently. So I'm going to finish by showing you our wonderful leaders, and I want to inspire you with leadership. It's all about your leadership. It's all about talking up. It's all about telling your managers, telling your colleagues, getting up to the Minister of Health. But this is Professor Julia Downing, so a nurse, and has worked in University of Makerere and Malaga Hospital and the hospice for over 20 years. Now back in the UK, but traveling to Uganda. So nurses in Uganda have been at the forefront of development. So she was part of a team. She doesn't say she did it. She said she was part of a team, did lead it, where the changes in the statute 2004 for the Ugandan Ministry of Health and Government, she enabled palliative care trained nurses prescribe oral morphine. And she has trekked many times, maybe like some of you, into the rural, where transport can't get, walked and walked and walked to their oral morphine. So they spent 16 years. It took them 16 years. With colleagues, we spent many years preparing, lobbying, and calmly presenting the case for nurse prescribing of oral morphine. Think that's possible? No. And why is that? Just hard? They won't listen? 16 years? Maybe in 16 years' time you can do it? Yeah, good. Okay, anyway, 18 years on, 18 years on, 2002, they did an evaluation of the prescribing of oral morphine by nurses. And the nurses have to fight all the time. They need to support and the utmost resilience and determination to overcome the challenges. And she said that collaboration has been key palliative team or palliative nursing for the development of palliative. Palliative nurses are leaders, so she decided it would be. She got the nurses doing the course and the evaluation was. But she said we all about out, and she now got a leadership at under Makerere University. She evaluates everything in it. So speak out and challenge and knock the doors of through your contact, your sphere of influence. You have many networking opportunities, and the International Association for Hospice and Palliative, I think they've got a meeting in India in February or something. So they're super. These are networking. These are we've got the ONAI, of course. The regional, you've got the Regional Oncology Nursing Association, which is the Asian Oncology Nursing Society. It was led by Professor Winnie Sue, and I think it's Eunice Sue that leads at the moment. International Federation of Palliative, I don't think so. I think they see something else. And the CEO of that for palliative care for children is Julia Downing. And then we've got many more. International Society of Nurses in Cancer Care. I'm here representing the global power of oncology nursing. So many networking opportunities, and use them. Don't be shy. So we're handing out cards here for the global power of oncology nursing. But look at this is for palliative care only. Look at the associations you've got in different associations. I haven't counted them up. 2, 4, 6, about 16 there, associations for palliative. And this isn't ONAI, this is palliative care. And the international one you should up if you. So the global palliative care partnerships, such as coming from are based on mutual respect relationships. Remember, they take time to build, but we are learning so much. And so haven't we learned so much? You have taught us so much in 3 days. And it's not just about the social events as well, which were absolutely super. You've taught us about nursing and the nursing, all the different disciplines, especially the mental health for cancer people. So sustainability, coordination, system strengthening, and good mental health. So this was written before we talked to the mental health nurses. What translates into good physical. So never ever in the cancer arena forget. But for healthcare professionals, and I'm talking about myself, just be aware of what you don't know, and with cancer, understand their life far better, and give them time to and talk. So, got small cards with the global power of oncology nursing. This QR code takes you to the WhatsApp group we've got to exchange all types of networking, comments, notices about scholarships and education. So the Multinational Association for Supportive Care in Cancer is in Japan this year. I don't need to tell you that. What I want to tell you is that nurses have a specific award that you may want to apply for. And remember, we said palliative care is part of supportive care. So I would like you to look up the website. And so there is a conference scholarship for nurses and doctors, and there's 5 available. Young Investigator awards if the nurses have been doing some research for it. And the Cynthia Rittenberg, who was the first, who was the CEO some time ago of MASC, has won for nursing. Was a nurse from the fabulous involved in supportive care. We would like you to be applying with your teachers and with your mentors for one of the come to Japan. Is that okay? So there are opportunities for fellowships as well. We just had the Global Power of Nursing, and we had awards. And I think the Rising Star Award was won by somebody in Hata, which was fantastic. So we'll let you know about these opportunities if you let us know who you are. I'm going to finish, we're going to finish on a video, which is the Pocketbook of Oncology. The Palliative, so this is a video textbook of oncology nursing from all over the world, low, middle, high-income countries, talking about every area of cancer. It's free of charge to everybody. High-income countries, we can sign up and pay for free of charge to countries for your certificate. You have to pay for it. And we're going to hear a video about this and the palliative care component of this by Betty Farrell, has been the international nurse leader, palliative end of life care and at end. So this is about global experts have given us their pocketbooks, 10 to 15 minutes. You can just pick what you want to. Everything, epidemiology, it's got loads on palliative care, it's got stuff on plots and cancer, it's got every toxicity side effect about cancer, plus the cancer sites. And it's super. You can just go in and take your 10 minutes, 15 minutes, and then come out again. So whatever you want to know about is. We all think that if we think back to our experiences with palliative care patients, we know, because we've experienced, the palliative care can be a transforming experience, both for the care, both for the people with cancer. And shooting for the moon is important, but I just want to stress again, so is shooting for a world that is just and equitable. So there shouldn't be that big disparity of care that we mentioned, and we would like to all help with that. The power of nursing is in your hands. You are the power behind good nursing care, whatever discipline you are. And the best way to find yourself is to lose yourself in the service of that, Megan. And we have seen over the last 3 days. Isn't that wonderful? And we have seen over the last couple of days and today the passion of your nursing. You have immersed yourself in the service of your cancer, but all the other patients. And it's just so wonderful. Thank you for your passion and thank you for your kindness. I'm just going to, I was just finishing on that. I'm just going to put on the video or somebody.
So before playing the video, there is one announcement that there is an online quiz going on in the biochemistry hall, and all the delegates who are willing to participate kindly proceed toward the students and nursing officers. Kindly proceed toward the biochemistry hall. Those who are willing, interested to participate. And so, fourth year students also. This is a competition and there will be top 5 prizes will be there and they will be awarded also, top 5 students. Please maintain silence.
From Northern Ireland, and I am the founder of Continuous. Continuous is a mission-driven organisation
Please,
helping
delegates,
doctors and nurses
students,
globally
maintain
to
silence.
access
There is
world
still the
expert
lecture is going
knowledge
on.
more easily and more fairly than ever before. You see, there has been a long-standing problem, one that I faced and I suspect you do too. Medical knowledge is accelerating and staying up to date is harder than it should be and generally easier for those that can afford it. We believe that all doctors and nurses globally should share an equal opportunity to access the subject expertise they seek. That is why continually. Hello, my name is Owen Colgan. I'm an emergency medicine doctor from Northern Ireland, and I am the founder of Continuous. Continuous is a mission-driven organisation helping doctors and nurses globally to access world expert knowledge more easily and more fairly than ever before. You see, there has been a long-standing problem, one that I faced and I suspect
we've got some leaflets on the pocketbook for
Medical
you,
knowledge is
and you're very
accelerating
welcome to
and staying
access it
up to
free of
date
charge
is
if you're
harder than it
interested.
should be.
And it's the
and
modern textbook, I think, cancer. Thank you.
Ma'am, kindly stay. Ma'am, kindly stay. And I request Ma'am, Principal Ma'am, to kindly extend token of love to Miss Annie Young. Dr. Meena Sudan Ma'am, kindly join. Please give a round of applause. Thank you, ma'am. Thank you, ma'am. Thank you, ma'am Annie Young, for sharing inquisitive information regarding palliative care.
We hope that the audience have attained vast information regarding the topic.
So knowledge becomes power only when we put it into practice, and if not, it becomes ignored. So knowledge grows exponentially. The more we know, the greater our ability to learn, and faster we expand our knowledge base, as per Dan Brown. So handling out the dice to Miss Harvinder and Miss Harjot for the next plenary session, which is the last plenary session of the conference, and of course for the day 3 also. So we will proceed with the plenary session.
Thank you, Sukhbir ma'am and Onkar ma'am. Good morning, all of you. I, Harvinder Kaur,
Jyotkar.
on behalf of SGRE College of Nursing, we welcome all of you on the last plenary session of day 3 of the conference.
Now we call upon the chairperson for the session, Dr. M.J. Kumari. Currently Professor cum Principal, College of Nursing, Jawaharlal Institute of Postgraduate Medical Education and Research, Member Secretary of Nursing Research Monitoring Committee, Institute Ethics Committee for Nursing Course, Member of Undergraduate Research Monitoring Committee, Intramural Research Fund Committee, Research Advisory Committee, Editorial Board Member, International of Nursing Practice by Red Flower Publication. She has participated in various international and national journals.
So, Dr. M.J. Kumari, we welcome you, please. Next chairperson, Dr. Prakesha Sharma. She is currently an associate in Baba Farid University of Health Sciences, Faridkot, Punjab, alumni of SMS Hospital, Jaipur, AIMS, New Delhi, and INCI PhD consortium. She is working in the field of oncological nursing for more than 14 years, written 38 original articles and 4 reviewed articles, 2 chapters. She is a member of PhD Screening Committee, Guide for PhD in INC, National Consortium, and BFUHS. She is an editor and reviewer in 11 national and international journals, member of DNAI, ONAI, NRSI, Red Cross India, Indian Science Congress, etc. Gargi Award of Meritorious Position in 10th and 10 plus 2 by Ministry of HRD GOI India, member IEC for PG program, member Inspection Report Evaluation Committee, BFUHS, committee member in PhD National Consortium Alumni, member of TNAI, NRSI, Red Cross, Indian Science Congress. She has organized several conferences, workshops, public awareness campaign, CNE, including ICMR funded workshops, etc. Now I would like to request Dr. M.J. Kumari to kindly introduce our first resource person.
Good morning to one and all. Miss Nancy, she is the MBA in Healthcare Services. So currently he is working as in charge for the Department of Nursing, and he has the post-basic diploma in Oncology Nursing from Tata Memorial Hospital and certified course of Central Venous Access Device from Tata Memorial Hospital affiliated with SNDN Mumbai. the certificate course of CPCR, the Tata Memorial Hospital, Mumbai. He has experience as a staff nurses in the Saint Martha Hospital, Bangalore for more than 2 years. You are welcome the speakers to present your topic.
A very good morning to all of you. So happy to see a large crowd over here. And first of all, I would like to take this opportunity to thank the organizers for inviting me to be a part of this conference. So coming to the hands-on training on central venous access devices. So before going on hands-on training, I thought I will just give a brief introduction about the venous access devices. So the venous access devices are mainly classified into three types. That is peripheral venous access device, which is also known as short cannula, midline catheters, or central venous access devices. So peripheral venous access device is mainly inserted by percutaneous vein puncture, generally into a hand or the arm area. And these cannulas need to be rotated every 72 to 96 hours as per the CDC guidelines 2002. So some of the disadvantage of this peripheral venous access is patients required repeated vein punctures to maintain the IV access continuously. And there can be infiltration, phlebitis, or catheter obstruction, which also interrupt the therapy. And all types of medications cannot be transfused through this venous access, especially irritant or vesicant drugs or parenteral nutrition cannot be transfused this venous access. So what is our responsibility as a nurses working in the clinical area? When the patients come to us for admission, we need to assess for the venous access, whether this patient is required a long-term treatment or only for few hours or few days. And also depending on the therapy, we need to decide which type of venous access patient is required. Is it for short term? Then we can and if there are visible veins on the patient's hands, then we can very well go for this peripheral vein access. Otherwise, we need to refer the patient for the midline catheters or the central venous access devices. So midline catheters are little longer in length, that varies from 7.5 to 20 centimeter long, and they are inserted through an antecubital fossa, and the distal end of the catheter lies at the below the level of axilla. And there even in midline catheter, there are complications that can occur, like deep vein thrombosis, dislodgement, occlusion, phlebitis, or infiltration. So these type of catheters can be kept in place from a few days, maybe 6 days to 8 weeks. And if the patients required longer treatment, like more than 8 days, then we need to refer the patient for the central venous access devices. So what is the central venous access device? It is the central venous access devices come into a polyurethane or silicone material, and they are also available either single, double or multiple lumens, and these catheters are directly inserted into a major vein, that is superior vena cava, and the tip just above the lying just above the cavoatrial junction. So we speak about the central line. What is central line or central vein? The central vein is the one near to the center of the circulation, that is the heart. So what are the main indications for central venous access devices? We all are working, or most of us are familiar with the oncology setup, or we are working in oncology department, and all the cancer patients that come to us are required of long-term treatment. And these long-term treatment also required a long-term access, venous access. So these patients, the cancer patients, one way or the other, they required chemotherapy. Maybe most of the patients require even parenteral nutrition, especially head and neck patients, GI patients. Then their cancer pain is very severe pain. Very often they required analgesics, and blood sampling is common. Every time before chemo, during chemo, after chemo, we require to check the counts of the patients. So they repeatedly required a prick and a sampling for the various investigations. Also, they required blood and blood product transfusions, and then antibiotics, plasmapheresis, stem cell harvest, or even for the CT scan to give the contrast. So most of these cancer patients required a central venous access device. So coming to the types of access devices, based on the lumen structure, they can be divided into single lumen, double lumen or multi-lumen. And this lumen, types of lumen, which type of, how many lumen catheter the patient required is decided by the treating physician. And the valves, depending on the valve structure, it is a open-ended and close-ended valves. So what is the difference between open-ended and close-ended valves? The open-ended catheter, the distal tip of the catheter is open. Since the catheter tip is open, it requires a clamping before entering into the system. And also it requires an heparin or Eplock flush in order to keep the patency of the catheter. And since it is an open-ended catheter, there is a higher risk for complications such as hemorrhage, air embolism, and occlusion from fibrin or clots. And also, if at all we are delayed in clamping, or if we have forgotten to clamp, then also there can be reflux of the blood into the catheter, and catheter can get blocked, and it may no longer use for the patient. So whereas closed-end catheters, the catheters are having three-way pressure activator valve to prevent the reflux of blood coming into the catheter. And the valve is closed, so we do not require an heparin or Eplock flush to maintain the patency, and also it does not require any clamps. So this is a closed-ended catheter. It has a three-way pressure activated valve. It has a three functions: the negative pressure, positive pressure, and neutral pressure. At the negative pressure, the valve opens inward, permitting the blood to aspirate and send for various investigations. The positive pressure opens the valve outward, allowing the infusions go into the system. And at the neutral pressure, the valve remains closed, preventing the blood reflux and clotting. And there is also a bullet nose tip, which is less traumatic, especially while on insertion. So coming to the based on insertion, there are four types of catheters. One is non-tunnel PICC, that is peripherally inserted central catheters, tunnel catheters, and implanted ports. So non-tunnel catheters, they are also known as percutaneous and non-cupped central venous access device. The catheter is inserted by puncturing directly into the skin and vein into the without tunneling the subcutaneous tissues. The most common example is the necklines, which are mostly used by the anesthetist for the shorter duration. And these catheters can be kept in place maybe up to 3 weeks. So indications are when there is difficult venous access, then we refer the patients to an anesthetist or to the ICU where they insert the neckline catheters. And also through these catheters, we can infuse the irritant drugs or vasopressors and short-term parenteral nutrition. So next is peripherally inserted central catheters. The most of the chemo patients or onco patients are having PICC lines, and these PICC lines are mostly managed by nursing staff, the care and maintenance, as well as most of our EMS centers where there is a training, certificate training course, and it is taught to those nurses how to counsel the patient, how to insert, treat the complications, even removal. So entire thing is managed by the nurses having CVD clinic. So this PICC is inserted in a peripheral vein such as the cephalic, basilic or brachial vein, and then advance increasingly into the larger vein, that is into a superior vena cava, and the tip lying just above the cavoatrial junction. The main indications are maybe difficult venous access, blood sampling, IV infusions, administration of irritant drugs such as chemotherapy, and also for parenteral nutrition. And these catheters can be kept in place more than a year for the entire treatment of the patients. So this is one of the example of PICC. This is a Groshong PICC, which is made up of silicone material, and it has a closed tip. You can see that there is a closed tip, and it does not have any clamps. It is a double lumen catheter. And this is a power PICC. This is made up of polyurethane material, and the tip is open. So main advantage of this power PICC is can give high flow rate of fluids, and it is also indicated for contrast media, whereas Groshong catheters may be difficult to give contrast, it may get blocked, but through this power PICC we can even infuse the contrast, then we can monitor CVP, and these catheters can be kept in place more than a year. Okay. Then comes the tunnel catheters. The tunnel catheters are tunneled proximal end of the catheter is tunneled subcutaneously from the insertion site and brought out through the skin to an exit site. And these catheters can be kept in place more than a year. And these tunnel catheters are mostly inserted by the surgeons in the operation theater. And the example is Ickman and Warwick catheters. Okay. These skin tunnel catheters are recommended for patients whose treatment is more than 30 days up to more than 1 year. We can keep it. And then there is a lower infection rates than those of non-tunnel catheters, because tunneling and there is a dacron cup reduces the infection due to fibrosis and catheter fixation. So this is the example of the white in color is a Warwick Ickman catheter, and the blue is a Groshong catheter with the dacron cup. And then last one is implanted ports, are also known as implanted venous access devices, and this implanted ports also are the procedure is done by the surgeons in the operation theater. So surgically it is placed into a vessel or body cavity or organ, and it is attached to a reservoir or port located under the skin. So the duration of these ports can be kept in place more than a year. The indication is long-term intermediate access. Example, patients with regular hospital admissions and poor intravenous access. We also can infuse irritant or vesicant drugs, one chemotherapy or blood and blood products through this. The main disadvantage is every time if you want to access the port, we need to insert a needle. Patient requires a prick. Okay, that there is a special needle for this port, that is non-coring needle or a Huber needle, and through this we can insert the needle and give the treatment to the patients. So coming to the comparison of these three types of catheter, that is non-tunnel, tunneled and implanted ports. The insertion is easy with the non-tunnel catheter, that is PICC lines, and tunnel catheter, that is Hickman or implanted ports. These are required in OT or operation theater, and it is inserted by the surgeon. The removal is easy with the non-tunnel and tunnel catheter, but implanted port required one more procedure. Then size and lumen of the catheters. The non-tunnel catheters varies from 0.5 to 1.5 mm in diameter, and it is available in multi-lumen catheters. Whereas tunnel catheters 1 to 1.6 mm in diameter catheters are available. Also available with multi-lumens. Whereas port, there is only two options, single or dual port. Then flow, coming to the flow rate, there is a high flow rate with non-tunneled and tunnel catheters, and implanted port, maybe it is little difficult, especially to transfuse the blood because it comes in thick consistency. Otherwise, we can give the chemo and other things. So dwelling time, all three tunneled, non-tunneled and implanted ports can be kept in place more than 1 year. Then patient's acceptance, coming to non-tunnel and tunnel is not very much accepted by the patients, because I remember once a patient came to my clinic. Actually, that patient required an PICC line, PICC insertion, but patient was not willing for it because it is visible outside. There will be dressing, there is the hub of the catheter is out. So patient was not willing at all for PICC line, but she was willing for port, because port is implanted under the skin and it is not visible externally. So cosmetically, the patients do not accept the tunneled and non-tunnel catheters, whereas port is very comfortable for them. So that is the end of this presentation. This is the end of this introduction. Before starting the video on hands-on training, I just want to give an information that I will not be showing the port, how to put this needle inserted or remove it, how to care for that. That is, we have kept one dummy outside, and one nursing officer is there. If anyone wants to practice how to exactly put the needle in and remove it, can be done over there. I will show you the care and maintenance of peripherally inserted central venous catheters, because this is managed by the nursing staffs, the care and maintenance. From the counseling, insertion, even managing the complications and the removal. Okay. So I know that many of the hospitals, even PICC lines are inserted by the treating physicians, but for the care and maintenance, they surely come to us, to the nursing department, to maintain it. So now we will go into a video. So when the patients come to us for the care and maintenance, First, we have to welcome the patient, make the patient comfortable, either on sitting position, supporting with the pillow under the arm, or lying position, supported hand. So before going to the patient, we have to assemble all the articles that are required for the care and maintenance. I am going to show how to do the flushing and how to do the dressing of the PICC lines. Okay, before that, we saw the trolley is cleaned with the antiseptic solution. Then the articles are arranged, the sterile gloves, the micropore to fix the catheter, the syringe for the flushing, taking the saline, normal saline. Then this is a bionectar cap. This is the antimicrobial solution for cleaning purpose. And this is a hexidine based hand rub. And there is a Tegar drum. There are two types of Tegar drums. One is plain and one is CGH, that is chlorhexidine gluconate patch Tegar drum. And even those two packs we saw, there is a two packs, Ickman pack and PICC pack. I will explain to you a little later. This is a Cavilon spray which acts as a skin protective before applying the Tegar drum. So now we have to remove the old dressing which is already there on the patient's arm. So before touching the patient, we have to use the hand rub using all the movement of hand washing. So if the patient has any skin rashes or skin infection, then we will not use the CGH Tegar drum, but we will use the plain Tegar drum. This is an adhesive spray which is sprayed over the dressing so that it is easy to remove the old dressing. The hub of the catheter which was removed and placed it on the arm. First we are going to do the dressing procedure and then flushing. So we have to remove the old Tegar drum, first loosening all four sides and then from down to the upward. Then we have to see that Tegar drum whether there is any infection, any pus or any blood over that. Okay, then we have to palpate the hand and see whether there is any thrombosis, thrombophlebitis or any swelling or any hard cord, so that to identify whether there is any complications. And also we have to see if there is any rashes on the hand. If there are rashes, then we will not do the chlorhexidine based cleaning, but we will use the betadine or betadine and plain spirit. Then we have to go and scrub our hands with the antiseptic solution, soap based. So what are our main objectives of doing this dressing and flushing? First of all is to prevent the infection from pathogens, microorganisms and prevent the site infection. Second is to secure this catheter in place for the entire course of treatment. And finally, to identify the early signs and symptoms of infections and treat them as early as possible. So the staff nurse has scrubbed her hands and the assistant will open the outer cover of this Ickman pack. Okay, and that is placed under the arm because to protect the bedding. And inside this pack there are two green towels. One is used to dry the hands and the other one is used when we do the flushing of the catheter to place the hub of the catheter on that sterile towel. Inside this towel there are two balls. One is used to if there is skin rashes, then we need betadine separately and spirit separately. So that's the purpose it is kept. But for this patient we are going to use chlorhexidine gluconate based alcohol spirit for the cleaning purpose. It is an antimicrobial solution. Once the hands are dried, then we have to use the hand rub and apply over all the fingers, the corners, just like a scrubbing. It is very important to maintain the sterility of the procedure to prevent the infection. Okay, and also before starting the procedure, we should close the windows if the windows are open. We have to put off the fan and then start the procedure. So once the hand rub is dried, then we have to use the sterile gloves. Even this procedure, the dressing and flushing, we teach the relatives how to do. They can even do it at home because this dressing and flushing is done every week. Once in 7 days, we have to do the dressing as well as flushing. If there is any infection at the site, exit site, then we may need to do every second day or every day depending on the severity of the infection. So now we have to arrange the articles. Those are there inside the pack. The gauze pieces, and there are buds. 7 to 8 buds are there to clean the exit site. And there are also small gauze pieces which are used during the dressing. And then we have to hold the ball in our hand outside the trolley because by mistake if spills, then it will wet the entire articles. So we have to use the bud, dip into the antimicrobial solution, and from the exit side, we have to clockwise go around for about 5 centimeters. And remember, every step that we are doing, we are repeating minimum 2 times. Okay, if it can be you done more than 2 times, if there is dirt or some blood clots to remove. This catheter is on the upper arm. These PICC lines also can be inserted in the lower arm. Since it is upper arm, you turn it and fix it. When we fix it, I will again tell you. So while doing the dressing, we have to straighten it and keep the catheter straight and fix it on the lower arm for the easy dressing. So now the exit side cleaning is over. Now we are cleaning the catheter which is outside with the gauze paste, holder dipped into the solution and kept over the catheter, and with one finger we have to stroke downward 3 times. So 1, 2 and 3, and then we have to clean that. Now we are going to clean the surrounding area. While cleaning the surrounding area, there are small gauze pieces. We have to place one of them on the exit side and clean the outer area. Sometimes there may be dirt or there may be micropore stick that is stuck on the skin. So we need to clean it completely. We are going to repeat once again. Every step, every procedure that we are doing, we have to repeat it minimum 2 times. Then we cut the gauze pieces. The cleaning of the exit site is over now. Now we are going to spray the Cavilon spray. It's only a skin protective agent. We have to cover the exit site with a small gauze piece and then spray the solution. Then we have to just allow it to dry minimum 30 seconds. Meanwhile, we will be opening the tegaderm. So this is a chlorhexidine gluconate tegaderm. There is a patch in between. If patient has any rashes or infection, we are not going to use this tegaderm. Rather, we will put a plain dressing just with the gauze piece, applying some cream and antiseptic cream or antimicrobial cream, and then we apply the gauze piece and then we place a plain tegaderm. So now this catheter is U-turn and fixed on the upper arm. This is to prevent the catheter coming onto the joints or antecubital area and thus preventing a discomfort or restricting the movements of the hands. So tegaderm is fixed. We have to fix all round, gently tapping it over and remove those strips, paper strips. It's all dressing. There are small strips that attached, so we have to remove and attach it. This is used for writing the date of the dressing. So patient and the relative also will be aware when that next dressing is due for the patient. And the other strip is put on the extended tube. And then we will be removing the gloves and put one small micropore piece over the covering half of the tegaderm. This is to place the hub of the catheter later on, and half of the tegaderm should be left visible. There is a transparent micropore, and through that we can see if there are any like any pus or blood coming out, or if there is any infection, we can observe it. And if it is there, then patient can very well come to the clinic and report it. So once that is over, we saw the outer, there is a gauze piece wrapped around the hub of the catheter and the micropore. The micropore is removed, and now we are going to do the flushing of the catheter. So before flushing, we have to again apply the hand rub, then use a fresh new gloves, the sterile gloves. Now we have to again set the tray for the flushing. We required syringe. Nowadays, we also get a pre-filled normal saline syringes. Okay, here we are using plain syringe and we are taking normal saline. Before freaking into the normal saline, we need to clean the top of the normal saline bottle. Then withdraw the 10 ml of saline. So please remember that while flushing the catheters, central venous access devices, we have to use only 10 ml of syringe, because the pressure which is within the syringe and the pressure within the catheter is equal. If we are going to use the smaller size needle syringes, for example 2 ml, 5 ml or 20 ml, there can be chances of rupture of the catheter. So we need to use only 10 ml syringe. The assistant staff will help you to remove the outer cover, the wrapped gauze, the old gauze piece, and place it over a sterile towel. So this is the towel what I mentioned earlier. There are two towels. One is used to dry our hands. The other one is to place this above the catheter. Then you have to take the gauze piece, fold it, dip into the antimicrobial solution and clean the, there is a bionectar attached to the hub. So we have to clean that bionectar before removing it. We need to discard that old bionectar and put a new one. But we need to clean before removing it. Because if there are any microorganism that should not enter in. So every procedure, every step we are doing twice minimum. Then we have to remove it, the old bionectar or the cap, and discard it. Then again we have to clean the hub of the catheter. Then we have to fix the new bionectar or the cap, and then we need to flush the catheter with the plain normal saline, because this is a Grosjean catheter and it has a valve. So it does not require an heparin or epilogue flush. We are just flushing it with plain normal saline. We are taking 10 ml of normal saline, but while flushing, we are flushing only 9 ml. And the 1 ml normal saline has to remain in the syringe. Why? And we have to keep it and count 1 to 10 and then only withdraw the needle, syringe. Why? To prevent the blood coming into the catheter. So there should not be negative pressure and blood entering. To maintain that, to close that valve, we have to wait for 10 seconds. Okay, once that is done, we will discard the syringe and then again clean the hub of the catheter. And then the cleaning process is over, the flushing is over, and now we have to wrap this with the sterile gauze piece. That's the wrapping is over. Now we have to fix this hub of the catheter on the micropore which we have placed earlier. Keep over that micropore and then put one more fresh micropore piece. So this is the final dressing that we can see. After dressing and flushing, the way it looks. Then we put the date over it so that we remember after 7 days. We also give a record to the patients where there is dates are entered each time when the dressing and flushing is done. Then we have to check the movements of the patient, very important, because sometimes the micropore may come on the antecubital area or the joints, or this is on upper arm, okay? So we have U-turned the catheter and fixed it on the upper ram. If it is on the lower ram, then no need of U-turning. If you U-turn again, it will again obstruct the joint movements. So we have to keep it straight and fix it. That is only the difference. So after it is done, after checking all that, patient is comfortable, there is no obstruction in the movements, all those things, then we also need to give some instructions to the patients. If at all accidentally the catheter comes out, what to do? Patient has to put one pressure dressing and come immediately to the CVD clinic along with the catheter. Why? Because we need to check the tip of the catheter. The entire catheter is out or not. Sometimes it can break and come out. So only half of the catheter will be out and the half will be inside. If it is inside, then it needs to be removed. We cannot keep the foreign body inside our tissues. So one thing, and second thing, if there is any rashes or patient feels any discomfort, if there is any blood or any infection or any leakage, then also patient needs to come to the CVD clinic as early as possible. So that is all about the dressing and flushing or care and maintenance of these PICC lines, and also port. Port, mainly there is only the main importance is insertion and removing of the needle. So we have kept the dummy outside with all the accessories. So all those who are interested to try, they can do it so. So thank you so much for patience listening. I saw a very thank you so much.
Thank you, Miss Nancy Diana, for sharing your experiences about CVR uses among cancer patients. It was really an enlightening session, ma'am. Next, moving on to our next topic for session.
Now, we invite Dr. Preksha Maheshwar to introduce our next resource person, Ms. Ruchika, for sharing information regarding therapeutic nutraceuticals in radiotherapy.
So, good morning, participants. We have just gone through such an interesting session by Ms. Nancy D'Souza, and now we are having the another wonderful session by Mrs. Ruchika Rani. And ma'am is currently working as assistant professor, College of Nursing, AIMS Rishikesh, and she has worked as clinical instructor at Shahid Kartar Singh Saraba College of Nursing, Saraba, Ludhiana, here only in Punjab. And she has been the life member of ONAI, and she has presented many oral papers at conferences and got awards for achieving the first position in national conferences. She has more than 20 national and international publications in indexed and PubMed journals. She has been editorial member of journal in IP International Journal of Medical Pediatric and Oncology. So now I invite Mrs. Ruchika Rani for next session. So have a great round of applause for her.
A very good morning to all of you. First of all, I would like to congratulate SDRD College, Principal Ma'am and their faculty for organizing such a wonderful conference. And also, I'm really delighted to meet experts and my gurus in oncology nursing. I would like to bow down in front of you all the experts that I got the opportunity to be here only. Thank you for the invitations. And the topic that has been given to me, that is therapeutic nutraceuticals in radiation therapy. This was the new topic for me also, and I did my best. This topic, it is nutraceutical. If we'll just have a small introduction about this topic. Nutraceuticals, I think it will, yeah. Nutraceuticals, they are the, like, if we'll say that the foods and medicine, because in ancient science, in the ancient tradition, we people, especially the Indian people, we used to give so much emphasis on the diet what we are taking. And still now we also feel that our grannies and always in our homes, they used to tell us, don't take medicine, first take ginger. Don't take medicine, use garlic if you can. Yeah, so it is like a tradition in India. In so many countries also, they are using the foods as a medicine. And it will see, as Hippocrates also use the same thing, that thy food, thy should be medicine. Let food be the medicine and medicine by the food. So same thing, that here we will talk about the nutraceuticals, because there is one era when we are like more putting more emphasis on the pharmaceutical companies only. And the objective of the pharmaceutical company, it was like that there should be one drug and one goal, that medicine should be acted only on the one organ only, but it is also creating side effects in many other organs also. So now they have added this part, that nutrition, because people are so much concerned about their diets, that what should be we take, rather than we have the disease and then we are thinking about the cure, why should not we think about the prevention also? So they have added nutraceuticals. The physical body is the product of diet and sensory input. Similarly, all the diseases are the result of non-correct diet and lifestyle. Diet and lifestyle, wholesome and unwholesome, are the foundations of health and illness. So when we see about the nutraceuticals, it is actually nutrition plus pharmaceutical. It is the combination of these two, you can say, disciplines. So in our history, our Indians, Egyptians, Sumerians, they have given so much emphasis on the nutrition to be used as a diet, as a medicinal only. So during the last 2000 years, Hippocrates emphasized the practice of medicine itself consisted largely of wise choice of naturally food products. However, like when I was searching about this on the topic that thy food be thy medicine, I was not getting so much content to prove that this theme has been given by the Hippocrates only also. But there is also controversy that these statements have been given by the Hippocrates, or because this is the Indian part, Indian tradition. So I don't have any that the bad feeling that why should not I mention this, because we realize we have experienced it also that. So he emphasized that essential relationship between food and health and differences of diseases depends on the nutrients. So first we will just discuss about the nutraceutical. This term has been given by Dr. Stephen D. Fallis in 1989. Actually, nutraceuticals, if we'll see the definition, it can be any food or it can be any product of a part of a food or nutrient that can provide health benefits, including the prevention and treatment of diseases. So what will be the nutraceuticals? What can be the, we'll see the categories of these things. It can be herbals, it can be fatty acids, probiotics, prebiotics, vitamins and minerals, amino acids and proteins. If we'll see our social media also, in so many advertisements, we can also see that even they are recommending so many vitamins, supplements also. People used to take these without even prescribing by the doctors also. They used, as we don't ask any physician that what vegetable we should eat and what vegetable I should cook in my home. Similarly, people are also consuming these nutraceuticals also as with their own choice, because I have seen on this particular during the ad, So I will also start consuming so many energy supplements they are taking without even prescribing. But this is also something putting a concern over this. Like, as it is, we are taking it without the prescription of the doctor, it is sometimes affecting the health of the people also. So this is the classification of nutraceuticals. Maybe you will be having idea. So like micronutrients, vitamins and minerals. It has a lot of like vitamins, minerals, fatty acids, so many micronutrients, selenium. These are the components of these things. And they are having the role, like we can say that selenium and also micronutrients, they act as anti-inflammatory agents. They also protect the body from so much inflammation, especially used for the arthritis people also, to prevent the osteoporosis, to prevent the heart diseases. Similarly, in the dietary supplements, coenzyme Q and carnitine, these are the also supplements people used to take even without the prescription also. Functional foods, probiotics and prebiotics. Probiotics, I think all of are having idea. Even sometimes we also consume in our like daily foods also. You can say it is yogurt or curd. We used to take it because actually it helping us to have these are the bacterias, living bacterias also, but they are helpful us for the gut health also, and they help us to absorb the nutrients from our intestine and also prevent the pathogens to get stick to the intestine. Polyphenols, flavonoids, still beans, it can be found in soya beans. It can also found in, you can say, legumes also. And terpenoids, carotenoids, monoterpenes, phytosterols, they are found in our whole grain foods, carrots, vegetables, fruits, and glucose inolates, garlic and onion. So we can see that these are the classification of the nutraceuticals, but we are consuming it in our daily practice also. But what the nutraceutical people they are doing, they are actually marketing it by combining our nutrition and adding the chemical components of the pharmacy. So categories of nutraceuticals can be classified on the basis of natural sources, what we are already studying, pharmacological conditions and chemical constituents. So first now, as the topic the topic has been assigned to me, it is the role of nutraceuticals in radiation therapy. So I think we are having some idea about the nutraceuticals now. So when we'll talk about the radiation therapy, as because from the last 3 days, you are studying about a lot about the cancer and the treatment modalities we are using for the oncology patients. One of this treatment modality is radiation therapy, and we know how it works. What is the principle behind the radiation therapy? So these are the high energy particles. Actually, these are the ionizing radiations which are acting directly over the DNA of the cell, and it is breaking the strands of the DNA. But when it is also breaking the strand, there is one principle which acts like it acts by producing the free radicals. I think you have studied about this also. So when the radiation therapy just attach the water component of the cell, it produces the free radicals, and these free radicals actually hitting, you can see here. So as the non-ionizing radiation is attaching with the water component, and it produces the free radicals, and it indirectly damaging the DNA, and similarly directly they are damaging to the DNA by producing the reactive oxygen species in the body. So this is how radiation therapy actually acts in the body. But this is the key point, you have to remember it, because in further my slides I will discuss it again. So there are so many side effects of radiation therapy. I will not go through all this detail. Fatigue, skin changes, low blood counts, hair loss, mouth sores, gum sores, memory or concentration problems, nausea and vomiting. While the patients are suffering with so many side effects because they are taking the radiation therapy as a therapeutic purpose, but if they're getting so many side effects, so people started to search for the other options also. So what could be the other options so they can protect themselves from these side effects? So they start taking complementary therapies also. It has been said that the data shows that 70% of Americans, they are using these complementary therapies and even the nutraceuticals without telling the doctors also. But if we are not telling these things to our doctors, Because the nutraceuticals, they are having the components they can, because these nutraceuticals, they help our body by reducing the free radicals in the body. So what we have seen in radiation therapy, DNA is actually getting damaged by the production of radiation therapy. And nutraceuticals, what they are doing? They are reducing the free radicals. So actually it is affecting the treatment modality. So whenever you are taking these nutraceutical medicines, especially during the radiation therapy or chemotherapy treatment, you should consult your doctors. You should tell your doctor that this type of other things you are consuming, because it can affect the treatment. So there are so many nutraceuticals based on the chemical and some traditional and non-traditional nutraceuticals also. We will not discuss in detail in here. So how these multivitamins and mineral supplements, it can affect while you are having the radiation therapy treatment. So some studies, they are in favor. They were telling that there are two large scale RCTs, they have been reported that reduced cancer incidence among men taking daily multivitamin versus a placebo. Similarly, there is one study, physician health studies on the physicians also. They were taking multivitamins and they have told that it reduced the incidence of cancer with hazard ratio 0.92. But there is lot of controversial data, because I have got the data which was telling that according to the American Society of Clinical Oncology and even the European Society of Medicine, Oncology Medicine, they were actually not in the favor of taking these nutraceuticals while you are taking the radiation treatment specifically. So data from the colorectal and breast cancer cohorts, they were showing that neither beneficial nor harmful effects of these supplements on the toxicity or survival. Similarly, there is one meta-analysis also. They have told that there is no overall beneficial or detrimental effects while taking the multivitamins. So while we are talking about the multivitamins, so they are saying that there is no benefit, but there is also no harm. So there is insufficient evidence to make the recommendations for the use of multivitamins. So actually we are having very promising data. We are not having so much data like on the basis of clinical trials, so that we can recommend that multivitamins can be used or it cannot be used. So there is one study, I think if you remember that we have heard that selenium reduced lung cancer, as it has been reported by, or some studies, even in our textbooks also we have studied that. But here what I got, selenium reduced lung cancer in population with low selenium status. Means people, those who are having low selenium content, they are having low chances of colorectal cancers, lung cancers. And increase rate in those with higher serum levels. So it have totally changed, or it is a controversial statement if we'll see the previous data. And reduced gastric cancer occurrence. So neither vitamin C nor selenium was beneficial. If we also see the result, as the relative ratio is also 1.02, 0.97, so it has been shown that it is not effective. So we will just talk in the legal manner. There is a suspect, selenium has been suspected, right? And charge is that selenium is a mineral found in poultry, fish, wheat, and liver. It was once thought to be the potential beneficial in preventing cancer. However, several studies have shown that it is not ineffective, but also potentially dangerous. Verdict, it has been, that is, we should not take it. Don't take it. It does not prevent skin, lung, prostate, stomach, and esophageal cancer. Furthermore, it may increase the risk of type of skin cancer called squamous cell carcinoma. So last year, even there is one trial was running with vitamin E and selenium for the prostate cancer prevention. This study has to be stopped in between, because it has been seen that the researchers has observed that the people, those who were taking this medicine, they were having small increase in diabetes among men. So they have stopped the study in between. Similarly, moving to the next, alpha tocopherols, beta carotenes, and radiation therapy. There is one study that has reported that supplementation with beta carotene reduced the severity of oral mucositis in head and neck cancer patient taking chemoradiations. Similarly, with high dose of alpha tocopherols and beta carotene during this therapy could reduce the severity of treatment adverse effects. But this trial suggests the use of high dose of antioxidants as adjuvant therapy might compromise radiation treatment efficacy. I think now you can understand why I was telling that these antioxidants should be avoided while taking the radiation therapy, because these are the only things, reactive oxygen species, that were actually acting on the cells to protect ourselves from the lethal cells. So, but now it will compromise the treatment. So in curcumin, that is haldi, turmeric, we all know. So in favor, we are having some data. It is well documented herbal anti-inflammatory agent. It targets various inflammatory mediators and attenuates the release of pro-inflammatory and pro-fibrotic cytokines, and even suppress the chronic production of free radicals, right? This is good if we are taking it as a, like, we are healthy. If we are healthy, we should take it. All the multivitamins and all these things, we can consume it if we are not having any other potential hazard to our body. This is also a radio sensitizer of multiple cancer as well as radio protector of several normal tissues. Even systematic reviews also confirm that it reduces the side effects of chemotherapy and radiation therapy. Lots of data and lots of studies has been done on curcumin and radiation therapy. They have shown that it has tendency to reduce the side effects associated with the radiation therapy, but it can affect the treatment modality by still broadly corroborative data, including the clinical studies, that curcumin is extremely safe, not harmful to a cancer patient undergoing radiation and chemotherapy. So it can be safely used, but charge is this. So we all know that it is a curry spice with having anti-inflammatory properties and contain antioxidants, that is curcumin. In very basic laboratory studies, it has been shown to stop the spread of melanoma cells, and researchers do not know whether it has any anti-cancerous effects in human, because most of the studies has been done in very low phases of clinical trial or sometimes in the animal models also. It has not been seen in such a large scale studies. So verdict is, a recent study showed turmeric may interfere with the chemotherapy for breast cancer, so avoid turmeric during chemo. It may also worsen gallbladder problems or slow blood clotting. It affects the blood clottings. Then moving to the next, omega-3 fatty acids and radiation therapy. In favor, we are having systematic reviews that shows that combination of omega-3 fatty acid supplements with conventional chemotherapy, it is beneficial and improve the nutritional and inflammatory parameters. Like 6, this is polyunsaturated fatty acids, statistically significantly reduce the chemotherapy related fatigue compared with O3 polyunsaturated fatty acids. But contrary, there is none of the studies reported worse outcome for the supplements. Fish oil contain the omega-3, right? So charge is this, that it contains, it helps the body to absorb nutrients and decrease inflammation. It also may prevent cancer and heart disease, but verdict is inconclusive because we don't have any such studies that can prove that it can be effective or not. So higher dose, it may impair the immune system and it can cause bleeding and even increase the risk of stroke also. So you can take it as a simple dietary product, but don't take it as a medicinal. Antioxidants and radiation therapy. So in the favor, we'll talk about antioxidant. It protects the normal cells from the reactive oxygen species. As in the previous slides, we have discussed how the free radicals produce the reactive oxygen. It may provide the same benefit to the cancer cells and reduce the efficacy of treatment. Because antioxidants, they're effective for cancer cells because they are attacking the DNA, right? But with same process, it is also attacking the cancer cells also, right? So it prevents short and long-term injury to the healthy cells, including tissue damage and increased risk of oncogenic transformation. It induces apoptosis in cancer cells and protect patient from painful side effects of radiation treatment. So, but the contrary studies, they are telling that there are so many trials they have summarized and have mainly been showing the negative reports with some notable harmful effects. When we are doing the supplementation with beta carotene, it increases the risk of lung cancer. It increases the risk of stomach cancer, while vitamin E increases the risk of prostate cancer and colorectal cancer. If you see the RR ratio, it is also showing the positive 1.74. So a recent meta-analysis also reported increased overall mortality with beta carotene. So the verdict is don't take it while having the treatment modalities. Then moving to the ginger and green tea. So especially in the winters, we all love ginger tea. And ginger is also known to control the inflammation, which play a role in cancer and nausea. Verdict is ginger supplements are not recommended. However, adding fresh ginger root to your diet and chewing the candied ginger for the nausea, it may be beneficial, but don't take the ginger as a medicinal. Excessive amount of ginger should be avoided. It may interact with blood thinners, and also it can lower the blood sugar level in people who are actually diabetic. Then suspect is green tea. There is charge. People who drink green tea, they seem to have low cancer risk, particularly CA bladder, esophagus, ovaries, pancreas, and breast cancer. It contains plant chemicals, polyphenols that act as antioxidants and anti-inflammatories. Verdict is drinking up to 3 cups of green tea, it is probably safe and have anti-cancerous effects. But if we are taking or consuming it in more numbers, it will produce more antioxidant. It can hamper the effects of radiation therapy. Then vitamin D. Most of our Indian population, they are having very less vitamin D when we used to get our serum levels checked. So vitamin D to reduce cancer risk, it helps to control cell growth and holds promise for cancer prevention. Verdict is research has not determined what dose of vitamin D is effective and safe for cancer prevention. So in the meanwhile, it has been told that we should take milk, or we can take we can use the sunlight for the vitamin D rather than taking the vitamin D supplements. If you are having vitamin D in normal values, then there is no need to take it as a like to control or to prevent the cancers happening. Vitamin D and radiation therapy. It is anti-inflammatory and immunomodulatory characteristics and their effects on the cytokines level. So how vitamin D can affect? It can affect the levels of cytokines which produces during the radiation therapy to kill the cancer cells. So vitamin D produces both radiosensitivity effects also and radioprotection effects. Radiosensitivity effect is good because it sensitizes the cells to have more radiation therapy and it will kill the cancer cells. But it can also act as a radioprotector. It can modulate the MAPK and phosphor-38 signaling pathways. It can enhance them. Rather than phosphor-38 signaling pathways need to be reduced to have the radioprotection effect. So there are so many nutritional supplements which can affect the radiation treatment. It can be ginger, it can be ACIC, hydrogen peroxide therapy, curcumin, juice plus, ashwagandha, acai berry, fish oil, omega-3 fatty acids. But there are claims are there, it should not be recommended, likely safe only curcumin, and juice plus is safe, likely unsafe, NONJ, acai berry, it is safe. Fish oil and omega-3 fatty acids are not to be taken. So the question arises, are the supplements safe? Natural doesn't always mean safe, because if we are consuming it in my experience, what I have seen that last when there's this COVID pandemic, all the people used to take kada. Everyone is just thinking of taking the kada only. And after that condition, we have so many patients, they were reporting that I'm having the problem, upset, GI upset, we are having something issues in related to the liver also. Because they were just taking without knowing what dose they should be taken, how much quantity to be added. But they were just thinking for saving their lives and they're taking kada 2 or 3 times, even sometimes 4 to 5 times as a tea. But it has having the bad effects on the health also. So similarly, natural doesn't mean that it is safe. most supplements in the US also, they do not need to be approved by the FDA like medications. Similarly, in India also, all the medications, specifically the nutraceuticals marketing, they are not be approved by the FDA, and they are giving the medicines just by advertising it on the social medias, and people are just recommending it by making a chain of, there are lots of companies, they are just giving it because you have to make a chain, you have to be a member of this particular organization, and they will give you some benefits. They will give you some cosmetic products, they will give you some benefits, so that you can just tell the other family friends to that you have to just do the marketing of their product. So supplements may not have what the label say. Sometimes it is written that it is ginger, but sometimes it is not actually that content. So they may have harmful contaminants such as lead, arsenic, cadmium, and more. So it can block other medication, and it can affect how your organs work. They are often taken without a person's healthcare provider or pharmacist being aware. So it can affect your treatment also. These are the supplements. It should be avoided when when the patient is having radiation therapy, like theanine, salimarin, vitamin C, vitamin E, vitamin A, coenzyme Q, quercetin, turmeric, lycopene, juice plus, green tea capsules. These things should be avoided while taking the treatment. Rather than after the treatment, when the treatment has been completed with doctor's prescription, it can be taken. So key takeaway for patients getting radiation therapy: any supplement, either it is vitamins, it can minerals, herbal cures, should be discussed with your provider. Should not take any supplements until you talk it. During radiation therapy, you need to take supplements you have been prescribed in the past. It doesn't mean that my friend is also taking, she has also been prescribed by the other physician, so I should also take. Don't take antioxidant throughout the treatment. There is a limited research supporting their use. So the number of antioxidant found in food is safe. If you are taking foods, juices, then it is okay. Otherwise, it can affect. So these are the references. Thank you so much. Any query or anything you want to add? Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, you should be avoided. Ma'am, it is all antioxidants. It is because of antioxidant. Because these vitamin C, it is also having anti-inflammatory properties. As we know that because the radiation therapy, when it is working, it is directly acting on the cancer cells by producing the oxidants, by producing free radicals. But these all vitamin C, they just reduce the free radicals in the body, and it can hamper the effect of treatment model. Ma'am, there is a lots of data. Even I talked about the oncologist also, ki what type of like these things we are giving into the daily practice. They're totally avoiding it. They're saying we don't recommend these things because it is affecting our treatment modality. Sometimes patient came with other complaints, or sometimes treatment is not effective. It is not showing same efficacy as compared to the other people. So they are telling if they have to take, they should just wait the completion of the treatment. After that, just to reduce the side effects, they can take after that. Otherwise, during the treatment, they should avoid it. Yes, ma'am. Yes, ma'am. Locally. Yes, yes. That high dose. Yes, yes. Because there is not lots of data, it is just only on the stem cells or simply on the animal models. Yes. Yes, yes, ma'am. It is also a conflict. There's a, yes, it can be. Yeah. Thank you, ma'am, for adding the knowledge.
Thank you, ma'am, for enriching us with information regarding nutraceuticals.
Now we'll hand over the dice to Mrs. Sukhbir Kaur and Miss Onkar Kaur. Thank you so much.
Now we call upon the chairpersons for the session to kindly honor our resource persons. Yes, chairpersons, kindly honor the resource persons. Ma'am, Miss Nancy.
Excuse me. So before honoring the previous speaker, I need one more clarification from her. She told that is catheter insertion and removal is as per your institute is done by the nurses. That nurses, they undergone any special training? And removal. So as your institute policy, you are allowing the nurses to do that. Thank you. Okay, okay. Okay. I understood those are undergone the training or the training person only allowed to do the procedure, not for everyone. Thank you.
Yes, resource persons, please. Ma'am Nancy and Ma'am Ruchika. Okay. Ma'am, please stay there only. Kindly, there. Please kindly. So now we request our ma'am, principal ma'am, Dr. Parvez Saini and Dr. Meena Sudan. She's ma'am, principal ma'am, kindly honor the chairpersons. Yes, Ruchika ma'am. Now we request principal ma'am, Dr. Parvez Saini to kindly honor the chairperson for the session. Yes, and ma'am, Miss Annie Young, Dr. Isabella can also join. Ma'am, please. Thank you, ma'am. Thank you very much. So concluding the conference after last plenary session, we can say that cancer care continuum used since mid-1970s describe various stages from cancer etiology, prevention, early detection, diagnosis, treatment, survivorship, and end of life. In this conference, like many other useful concepts, the continuum is clarified to a greater extent, I hope. And now I would like to call upon Mr. Hemant from CBS Publishers. He will be taking just 5 minutes, and they want to just give an outlook regarding their publication and their books, which are related to nursing. So delegates, be seated, and as after 5 or 10 minutes, we are going to have a valedictory session. So you have to be seated.
Good afternoon to everyone. First of all, I would like to give a thanks to organizing committee of SGRD and Dr. Parvesh Saini, Madam Principal of the college. Thank you so much, ma'am. And Vice Principal Manpreet, ma'am, to interact with the wonderful audience. It's an opportunity to interact with the wonderful audience. It's an honor for me to be here in front of the nursing fraternity, respected principals, faculties, and nursing aspirants, right? I am just starting my presentation with the one famous quote: gaining a knowledge is the first step to wisdom. Sharing a knowledge is the first step to humanity. My name is Hemant Upadhyay. I am coming from CBS Publisher and Distributors Private Limited and Nursing Next Live. Nursing Next Live is a venture of CBS Publishers with a strong vision. Our vision, we have to provide a good and quality content to the nursing student in terms of lectures, in terms of a questions bank for those students who are preparing for staff nurse examination as well as undergraduate students, right? So it's the platform Nursing Next Live we are providing for all faculties. Agar faculties want to see all the free contents, demo classes from the Nursing Next Live. So please it's my request to the all nursing faculties and students to download the application from the Google Play Store. It is the first slide. That is the interface of the application Nursing Next Live, right? Here you can see the name. When you download it from the Google Play Store, you have to complete a sign up process. Then you will see interface of the application. That is the Nursing Next Live interface, right? In the interface, you will see the plan 0. That is free to all. Here you can access all the content that is free of cost to the students, like a live test, previous year questions paper, MCQs, recorded lectures, each and everything you will get under the plan 0. That is a free of cost, right? Apart from it, we have a plan A, that is a crash courses plan with test series mastermind pack. That is a complete package for the students to prepare think about the staff nurse examination. Then you will see the rapid revision, right? It's the interface of the applications. It is for those students. We are just thinking we are bringing learning to the people instead of people going for the learning. So you can download the application and please explore the free content. Agar faculties, if you think about it's good for the students, so please first you check it, what content we are providing on the application, and if you think it's good for the students, so you can recommend it to your students, right? It's a Nursing Next Live. in application, as you know very well about the CBS publisher, we are also publishing books for the nursing and medical students. And yes, through the application, we are also providing access of the physical, physical content, right? Books plus digital. So you can also access of the digital, books on our application. So you can also check it out now. Then we have a Nursing Next social platform, India's first knowledge sharing network platform for the nursing segment. So please be the part of the informative session in the form of webinars conducted with the top-notch nursing societies like TNI, SONCH, NTA, and other nursing societies. Last but not the least, we put our nursing books exhibition here in a stall. So please, it's my small request to the faculties and nursing, principal madam and students, please come to the our stall and see the books and if you want to know information about more information about the Nursing Next Live and books, please visit our books stall, है ना? And thank you so much for giving me a time. Thank you, madam, है ना? And last, madam, I'm just finishing my presentation. Future belongs to those who believe in the beauty of their dreams. Thank you so much.
Thank you, sir, for briefing about your publication. And now we will be proceeding with the valedictory session in just 5 or 10 minutes. And by that time, we will have a glimpse of the 3-day conference. We can have. Thank you. Hope you have enjoyed this glimpse. So within few minutes, we are going to start a valedictory session. We have to be patient for that. Okay, anybody want to voluntarily give any performance? We can enjoy for that for a few minutes. If voluntarily anyone want to sing or show his or her talent, special talent, because all of you might be bored in these 3 days. So yes, anyone? Okay, again. Okay, ma'am's video. Yeah.
My name is Owen Colgan. I'm an emergency medicine doctor from Northern Ireland and generally easier. My name is Owen Colgan. I'm an emergency medicine doctor from Northern Ireland and I am the founder of Continuous. Continuous is a mission-driven organisation helping doctors and nurses globally to access world expert knowledge more easily and more fairly than ever before. You see, there has been a long-standing problem, one that I faced and I suspect you do too. Medical knowledge is accelerating and staying up to date is harder than it should be and generally easier for those that can afford it. We believe that all doctors and nurses globally should share an equal opportunity to access the subject expertise they seek. That is why Continuous aims to put world expert knowledge in the pocket of every healthcare professional worldwide. So let me introduce to you the Pocketbook of Cancer Care Nursing, one of many pocketbooks we are creating across multiple healthcare specialisms. Now, there are over 120 lectures on the core topics in cancer care nursing delivered by leading global experts. So whenever you need to improve any areas of your practice, you can access a leading authority on any digital device whenever you need it. Now, this has been created in partnership with Global Power of Oncology Nursing and the International Society of Nurses in Cancer Care. And the pocketbook was peer-reviewed by an independent advisory board of international experts, ensuring that this is one of the most credible and trusted resources in cancer care nursing. Now, we don't believe there should be any barriers to knowledge, so the lectures are free to watch for everyone in the world. For the optional premium extras, including CPD and CE accreditation, time-coded note-taking, downloadable slides, summaries of learning, and more, there is a low-cost subscription or an organizational license, which is fairly priced in middle-income countries and free in low-income countries. Plus, we donate a minimum of 4% up to 14% of profits to global healthcare projects, completing our mantra of free, fair, for. Free knowledge, fair pricing for premium extras, and a minimum of 4% to support healthcare education worldwide. So the key benefits for you now have world expert knowledge in your pocket, helping to build skill, confidence, and satisfaction at work. And should you choose to take a premium subscription, you'll acquire your CPD and CE easier than ever before, plus you'll be helping us to provide impact globally. Key benefits for organizations: they can now provide staff and trainees with world expert knowledge, supplementing your in-house teaching with guest international speakers, saving your team time and effort. You'll build skill, confidence, and morale in your teams, contributing to high standards of care. And together, we are championing paperless and travelless education, which is great for the environment. We provide equal opportunity for all clinicians to access expert knowledge, and improved access to knowledge contributes to high standards of care globally, a benefit for all citizens of the world, including you and I. We've created a special webpage where you can access a free lecture plus other relevant information. So please visit www.continualist.com/LP/cancer care nursing. And from there, you can sign up for a free account. Now, if you represent a hospital, university, or national society, we can provide numerous benefits for your organisation and your teams. So please email me at info@continualist.com for a demonstration. Thank you very much.
This video was compiled by Miss Annie Young and about pocketbook cancer care nursing. It was about that. Thank you, ma'am. So anyone from any state, those who have right from other states, they want to represent their culture in any form, can please volunteer. Or should I? Or should I do? Represent our Punjabi culture. So I will start with the tappe. Punjabi people, they might be knowing about that. So, बाईसाइकिल चलाई जाने ओ, बाईसाइकिल चलाई जाने ओ थोड़ी की लगदी जिन पिछे बिठाई जाने ओ थोड़ी की लगदी जिन पिछे बिठाई जाने ओ. Now from the audience, please respond. चलाई जाने बाईसाइकिल चलाई जाने ओ साड़ी ओ लगदी जिनू पिछे बिठाई जाने ओ साड़ी ओ लगदी जिनू पिछे बिठाई जाने कोट किल्ली उत्ते टंगिया करो कोट किल्ली उत्ते टंगिया करो साडे नाल नहीं बोलना साडी गली भी ना लंघिया करो साडे नाल नहीं बोलना साडी गली भी ना लंघिया करो. Yes.
गली ताडे प्यो दी नहीं असी रोज इथों लंघांगे नहीं असी रोज इथों लंघांगे गड्डी चलदी नू लुक लावा गड्डी चलदी लुक लावा अज मेरे माये ने आउणा वाल तो के क्लिप ला अज मेरे माये वाल तो के क्लिप लावा
गड्डी चलदी रेलां ते गड्डी चलदी रेलां ते
अगे माया
नाली ते मिलदा हुण मिलदा ए मेलां ते
गलत बोलिया
लीकां दे हाँ यस गड्डी चलदी खड़ो गई ए गड्डी चलदी खड़ो गई ए जिदे लई तू उतरी ओदी बदली हो गई ए ਜਿਹਦੇ ਲਈ ਤੂੰ ਉਤਰੀ ਉਹਦੀ ਬਦਲੀ ਹੋ ਗਈ ਏ
ਕੋਠੇ ਤੇ ਖਲੋ ਮਾਇਆ ਕਿਲੇ ਸਾਨੂੰ ਤੇਰੀ ਲੋ ਮਾਇਆ ਚੰਨ ਪਾਵੇਂ ਨਾਨੇ ਨਾ ਚੜੇ ਸਾਨੂੰ ਤੇਰੀ ਲੋ ਮਾਇਆ
ਥੈਂਕ ਯੂ
ਗੱਡੀ ਚੱਲਦੀ ਏ ਤਾਰਾਂ ਤੇ ਅੱਗੇ ਮਾਇਆ ਨਿਤ ਮਿਲਦਾ ਹੁਣ ਮਿਲਦਾ ਕਰਾਰਾਂ ਤੇ ਅੱਗੇ ਮਾਇਆ ਨਿਤ ਮਿਲਦਾ ਹੁਣ ਮਿਲਦਾ ਕਰਾਰਾਂ ਤੇ
ਗੱਡੀ ਚੱਲਦੀ ਏ ਕੰਡੇ ਕੰਡੇ ਗੱਡੀ ਚੱਲਦੀ ਏ ਕੰਡੇ ਕੰਡੇ ਅੱਗੇ ਮਾਇਆ ਨਿਤ ਮਿਲਦਾ ਹੁਣ ਮਿਲਦਾ ਏ ਸੰਡੇ ਸੰਡੇ ਅੱਗੇ ਮਾਇਆ ਨਿਤ ਮਿਲਦਾ ਹੁਣ ਮਿਲਦਾ ਏ ਸੰਡੇ ਸੰਡੇ ਯੈਸ ਐਨੀ ਵਲੰਟੀਅਰ ਪਲੀਜ਼ ਕਮ
ਕੋਠੇ ਤੇ ਮਾਇਆ ਭੁੱਲ ਗਿਆ ਲੋਕਾਂ ਪਾਏ ਮਾਏ ਲੰਘਿਆ ਮੇਰਾ ਵੀਰ ਸਕੂਲ ਗਿਆ
ਥੈਂਕ ਯੂ ਮੈਮ ਥੈਂਕ ਯੂ ਵੈਰੀ ਮਚ ना आशिक तेरे ते आशनी Thank you very much audience for supporting. So our guests are arriving within 2 minutes. Yes, sir has arrived. Give a warm welcome. Please give a round of applause. Thank you, sir. Thank you.
So now we are moving toward valedictory session. So starting with the valedictory session, we would like to extend floral welcome to our worthy chief guest, Dr. Manjeet Singh Uppal, Vice Chancellor, SGRD University of Health Sciences, and guest of honor, Ms. Rita Likhani, Vice President of ONAI, and Ms. Anita D'Souza, Secretary of ONAI. So we request Principal, Ma'am, Dr. Parvez Saini to do the floral welcome. Please, Ma'am.
Dr. Manpreet Kaur, ma'am, please join for the floral welcome. Guest of honor, Dr. Rita Likhani, ma'am, and ma'am Anita D'Souza. Ma'am, Miss Anita D'Souza. Thank you, ma'am. Thank you. So now we request the dignitaries to please share the dice. So we call upon our enthusiastic organizing secretary. Where is she? Ms. Rupinder Kaur, Associate Professor, who has worked throughout day and night to make this conference successful. She is the organizing secretary for the conference. Next, we call upon our ardent and passionate Dr. Manpreet Kaur, Vice Principal, SGRD College of Nursing, who has also equally contributed in making this conference a success. So no words can define this personality, our very compassionate, kind lady and serene personality, our principal ma'am, Dr. Parvez Saini. So who is behind all this work and helping us through day and night. Thank you, ma'am. Next, to honor the dais, I call upon Miss Anita D'Souza, Secretary ONAI. Thank you, ma'am, for making this conference a success. So, ma'am is also very enthusiastic lady, as I've seen in 3 days conference. Thank you, ma'am. Next, I call upon Dr. Rita Lakhani, a very inquisitive and knowledgeable person. She is a Vice President, ONAI. Dr. Rita Lakhani, please give a huge round of applause for her. She is the Vice President of ONAI, Oncology Nurses Association. So, Ms. Anita D'Souza and Dr. Rita Lakhani are the guest of honor for the day. And not but the least, so I call upon our very dynamic, eminent, and worthy personality among us, our Vice Chancellor, SGRD University, Dr. Manjeet Singh Gopal. Sir, we welcome you. Thank you for believing in us and helping us to organize this conference and making it a success.
Valedictory session can't be concluded without acknowledging the backbone, His Majesty, a great visionary and revolutionary Dr. A.P. Singh, Dean SGRD University of Health Sciences and Additional Secretary of SGRD Trust. So conferences are venue for updating knowledge and sharing the phenomena explored by various personnel of particular profession. So nursing is a routine profession which need upliftment in the form of conferences and workshop, which will reflect evidence-based practices. As we have seen in these 3 days of Oncology Nursing Conference organized by SGRD College of Nursing in collaboration with ONAI. So now we request to Dr. Parvez Saini, Principal SGRD College of Nursing, to deliver her speech.
And welcome all the dignitaries.
So good morning, everyone. Now we are well acquainted with everybody, and I think in these 3 days we have make a friendship also and gain a knowledge also. And I think everybody must have enjoyed our. Did you enjoy or not? So thank you so much. Good morning, everyone, and a very warm welcome to all of you again on this 20th National and 4th International Oncology Conference on the theme One Team, One Dream, Let's Uplift Healing and Caring Across the Cancer Continuum at Shri Guru Ramdas University of Health Sciences, Shri Amritsar, organized by SGRD College of Nursing and Oncology Nurses Association of India on this valedictory day. So on this on the third day of this conference, I, Parvez Saini, Principal, SGRD College of Nursing, behalf of organizing committee, feel extremely honored to introduce and welcome our chief guest, Dr. Manjeet Singh Gopal, that is a Vice Chancellor of SGRD University of Health Sciences, very dynamic personality, and he is a renowned surgeon and well known for his expertise and knowledge, and avid administrator. He has always been a source of encouragement and constant pillar of strength. I welcome you, sir. I am extremely thankful to our Dr. A.P. Singh, though he is not here, but I must acknowledge him. He is a Dean, SGRD University of Health Sciences, and the chairperson of this conference. I thanks for his wise advice and brilliant suggestions on organizing this event. Our guest of honor, Ms. Anita D'Souza, is one of the most esteemed personalities currently holding the chair of secretary in ONAI and also positioned as professor cum principal at College of Nursing, Tata Memorial Hospital, Mumbai. Ma'am has received major awards and an appreciation token in her field of work. I welcome you, ma'am, for your gracious presence. I welcome Ma'am Ms. Rita Lakhani, guest of honor, for the today's event. She is Principal, Jupiter College of Nursing, and members of various professional organizations and Vice President of ONAI. Madam is a gold medalist in MSc and having various publications and awards in her credit. There are a lot of contribution from all the from both the person from both the guest of honor, but because of the shortage of time, so I won't be telling you in brief. You all must have observed their talent and their potentials. So I extend my warm welcome to Dr. Manpreet Kaur, Vice Principal, SDRD College of Nursing, and Ms. Rupinder Kaur, Associate Professor and Organizing Secretary of this gala event. I also welcome and thanks all the delegates, resource person, chairperson, participants, students, faculty, because it's because of you only that we are able to complete this gala event. So thank you very much. And because of you people generous contribution, this conference have set another new record. We also appreciate the cadre of sponsors for supporting this conference. As we are concluding the conference today, so hope you all would have enjoyed to create long-lasting memories of your visit to this holy city Amritsar, as well as the hospitality offered by SGRD University of Health Sciences. So I again take this opportunity to welcome you all in this esteemed event. Thank you so much. God bless you all. And with the blessings of God and with the divine souls whole who are sitting over here, so we could achieve our target today. Thank you so much.
Thank you, ma'am, for warm welcome. These kind of conferences will never be a success without the support of some worthy and visionary people. Among one of them is our Vice Chancellor, Dr. Manjeet Singh Uppal, and SGRD University, and he's the chief guest for the day. So I kindly request, sir, to please share a few words regarding the conference. So concluding the conference.
Good afternoon, everyone. I think the whole team, Madam Sushma Saini and the organizing secretary, Dr. Rupinder, Ms. Manpreet, and all the organizing team, they deserve a good pat on their backs for executing this conference so wonderfully. And being a maiden international conference still, I think everybody has tried to give you the maximum, make a good show. But in spite of that, even if there are a few discrepancies which might have occurred and inadvertently left, so please excuse us for that. And I again think that, in fact, I would like to welcome you all again in the next event when we go for the second international conference very soon. And I hope we'll do better and better. And being a maiden conference and everything was, meticulously planned as per the team. And not to forget about, like Madam said, Dr. A.P. Singh, he is the main engine behind all this. So engine you cannot see, but you can hear the engine. You just see the car is moving and everything is going on. So you don't see the engine actually, but he is there. And he is there, and it's all because of his maneuvering and constant guidance that everything was done so perfectly. So I again appreciate all the guests who have come from far off places to grace this conference, and I hope that everybody had a good time and they'll take back good memories of this event. And again, looking forward to see you all again in the next event. Thank you so much.
Thank you, sir, for kind words. Now we call upon the Dr. Rita Likhani, Vice President, ONAI, and Principal, Jupiter College of Nursing, Mumbai, Maharashtra, to share her experience about the 3 days of conferences.
Respected Honorable Dr. Manjeet Singh Uppal at Guru Ramdas University Health Sciences. At the days and off the days, a very pleasant good afternoon to all of you all. It's a pleasure to deliver the valedictory address on behalf of ONAI. I think over the past 3 days here at SGRT University, we have learned a lot and we have enjoyed a lot. So the 4th International and the 20th National Oncology Conference themed One Team, One Dream, Let's Uplift Healing and Caring Across the Cancer Continuum was a very happening one, with approximately a little less than 40 speakers being connected and present over here. The team of speakers took us through the evidence-based care and gave us deeper insights into various topics on cancer as colorectal cancer, cancer breast, head and neck cancer, palliation care, leadership and communication with patients, and of course, hands-on experience skill stations. The scientific paper presentation was an effective way to try out new ideas, introduce one's work to colleagues, and hone the research questions. Certainly, they have even received valuable feedback from the community of scholars for increasing professional stature in the field. And finally, the quiz today came as a pleasant, motivating surprise for the students. I'm sure all of this knowledge bundled together will undoubtedly be valuable for each one of us as we go forward in life. And I think amongst the most important things that we have learned over here during the past 3 days is how to build relationships and rely on each other, how to work together as a community, how to respect each other's differences, and much, much more. Perhaps even we learned that we need each other to succeed and work together. Finally, excursions to the holy place Golden Temple and the historic patriotic spot, that's a Wagah border, is going to be immemorable for all of us. These thoughts will be nourished for days to come. The fabulous party, the incredible hospitality, and the mouth-watering meals are the warm memories that we're going to cherish for years to come, along with the gala party that we had yesterday, and bundled with the amount of knowledge that we have gathered. All this makes me proud of the team and all of them who contributed to make this conference a great success. A huge amount of credit goes to the team, SGRT, and I request all of you all to join me in giving a huge round of applause to the organizing team at SGRT. I really tip my hat to all of you. At the same time, let's also acknowledge the work that was done by a wonderful person as Ms. Pratibha Jagdish, who's the president of Oncology Nursing Association of India. She has meticulously worked even when she was sick with that broken leg, trying to connect to see that this conference is a big success and goes on seamlessly without any problem. Let's hope that she has... Let's hope, and I hope all of you all join me in praying for her quick recovery. I place my deepest appreciation and regard to SGRT team for opening the Punjab chapter and bang starting off with an international conference. It requires charismatic leadership, good communication, a clear sense of direction, and tons of persistence and patience to leave no stone unturned, and that's what you all have achieved. I would like to close by a quote from Abdul Kalam. Open quote. Learning gives creativity. Creativity leads to thinking, and thinking provides crystal knowledge, and knowledge empowers you to take ownership and leadership. Quote closed. Hope we can all compile all the proceedings and suggestions and forward it to our AD, Achila ma'am. The conference has led to many openings and many opportunities I can see, and we need to tap all those resources. Thank you so much.
Thank you, ma'am, for appreciation. Now we call upon the stage Ms. Rupinder Kaur, Organizing Secretary, will deliver report of conference.
Good morning, good afternoon to all. Being an organizing secretary, I hereby going to present the conference report that is organized jointly by Shri Guru Ramdas University of Health Sciences along with ONAI from 1st to 3rd December 2022. So, inaugural session was graced by Dr. Achla ADG Nursing, Director General of Health Service, Government of India, Dr. Puneet Girdhar, Ms. Anita D'Souza, Dr. Rita Likhani, and Dr. M.G. Kumari, Principal, GIPMER, Pondicherry. So it is the great matter of honor that we have received a huge response from national as well as international. That is, more than 700 delegates had registered from different states of India like Pondicherry, Rajasthan, New Delhi, Uttarakhand, Maharashtra, Haryana, Uttar Pradesh, Assam, Meghalaya, Himachal Pradesh, Kerala, Karnataka, Jammu Kashmir, Ganganagar, Gujarat, and Punjab. But one good thing is that is we have received 71 on-spot registration. This is the big. Apart from this, in this conference, we have planned 3 keynote session, 4 plenary session, 1 interactive session, 1 symposium, 1 open discussion, and 1 hands-on training on CVAT, that is coronary vascular access device. And in this, 40 experts in the field of oncology nursing had shared their innovative ideas, valuable experience regarding the patient care. Apart from this, we have also interactive session of patients and their relatives regarding their cancer experience, which were followed by the challenges faced by the staff nurses while caring for the cancer patients. So being an organizing secretary of this conference, I am very proud to say that it is the first time that is even the nursing officers from the different hospital like Guru Gobind Singh Faridkot, SGRD Rotary Cancer Hospital, from Advanced Cancer Institute Bathinda, PGI, and from SDH Khanna, the nursing officer had participated as a resource person in this international conference. So I congratulate all the nursing officers for deliberating their valuable knowledge and experience with all of us. And in this conference, we have get the equal response from the nursing officer as well as from the nursing faculty. So I again congratulate the nursing officers. And one more thing, that is the hand-on the training on the coronary vascular access device. It is again demonstrated by nursing superintendent Miss Nancy Diana from Homi Baba Cancer Institute. So apart from this, we have total 26 paper presentations and 15 poster presentations during the scientific session by the young researchers. So we are also enjoyed the last night mega gala event at MBS Resort. And as today is the last day of the conference, so with love and gratitude, I congratulate all of you who have adjusted their busy schedule and make this event a great success. Thanks a lot.
Thank you, ma'am. Now we request Dr. Parvez Saini, ma'am, to honor our chief guest, Dr. Manjeet Singh Uppal, Vice Chancellor, University, SGRD, University of Health Sciences, and also guest of honor, Dr. Rita Likhani and Miss Anita D'Souza.
Ma'am, kindly honor our guest of honors also. Is Miss Anita D'Souza and Dr. Rita Likhani. And Dr. Manpreet and Ms. Rupinder kindly accompany to the honors. Thank you, ma'am. So kindly, we're starting with the felicitation ceremony. So awards being given for the poster presentation. Poster presentation, we have the So any guesses for the paper presentation? Third position. Yes, ma'am. So, ma'am, Miss Anita, kindly, she has to conclude for the conference. So, ma'am, please come on the dais.
Good afternoon, all. I have not come to conclude, but maybe towards conclusion. Yeah, and let me just clarify one thing, that I am not the guest. I am a part of this place. So, but anyway, thank you for the honor. And at the outset, I extend my heartiest congratulations and felicitations to the Punjab chapter, which is initiated by the SGRD College of Nursing for organizing this wonderful conference. And we've really had lovely time being here with all of you. And also thank you for starting this chapter and paving the way for the development of oncology nursing in this part of India. Like mythological Samudra Manthan, which produced many gems and nectar, which is nothing but Amrita, I wish and hope that this chapter will come up with several practice recommendations and policies for achieving much desired goals of competent and comprehensive nursing care across the cancer continuum. The subject of holistic care is very vast and may involve many components, but the principle will remain the same. That is, the requirement of skill and the knowledge by the nurses or the healthcare providers, and also of the psychosocial dimensions of the patient that impacts them and their loved ones. Many roles that are played by the oncology nurses, right from the diagnosis till the patients are either cured or they come to the end of life stage. The multidisciplinary team approach and the collaborative care. Special thanks to Dr. Parvesh Saini, Rupinder Kaur, Dr. Manpreet Kaur, and the entire faculty of the SGRD College for having us and the great hospitality that we've enjoyed over the last 3 days. And I wish all the best and looking forward to have many collaborations with all of you, with our Punjab chapter in future. Thank you very much.
Thank you, ma'am. So now finally concluding with the felicitation ceremony. So I request all the dignitaries to please give away the prizes for the paper presentation, poster, and the quiz competition, which is being held from last 3 days. So kindly, please. So paper presenter, I call upon our third position goes to, there is a tie between two people, Miss MJ Kumari and Miss Shweta Gag. So ma'am, please come forward to take the prizes. Second position goes to Miss Ramandeep Kaur Bajwa. Ms. Ramandeep Kaur Bajwa, kindly give a huge round of applause for the winners as well as for the presenters also. So Ramandeep Kaur Bajwa is a student from SDRD only. She has passed her masters from SDRD college only. First position goes to Prabhu Murugan. Mr. Prabhu Murugan. So Ms. Shweta will take his award. So these were the winners of the paper presentation, and also give a huge round of applause for the presenters also. All are equal winners. So next, the poster presentation. Tag number 13. This got the third position. Tag number 13. Second position goes to tag number 14. Ms. Bhavna from Yukon, Faridkot. And the first position goes to tag number 9. Tag number 9, Ms. Kiran, Assistant Professor, SGRE College of Nursing. So that was about the scientific poster presentation, and one prize we have for the free poster. That goes to tag number 1. Mandeep Kaur, she is also demonstrator in SGRD College of Nursing. So we have winners for quiz competition also. Mr. Hemant from CBS Publisher. Kindly give the names of the winners. Mr. Hemant. So he will announce the winners. So, okay, before announcing the winners for the quiz competition, so organizing is what you do before you do something, so that when you do it, it is not all mixed up. That is what the team of SGRD Nursing College has proved in the last 3 days conference. So by doing untiring efforts throughout the day and night, with the support of the management, SGRD University of Health Sciences, we feel very privileged to honor the organizing team. So starting from the organizing team, the leader, visionary of our team, Dr. Parvez Saini. I request Dr. Manjeet Singh Uppal to kindly honor Dr. Parvez Saini, Principal, SGRD College of Nursing. The next, ma'am, Dr. Manpreet Kaur, Vice Principal, SGRD College of Nursing. Ma'am, please receive the honors. Next, I call upon Professor and Head of the Department, Psychiatric Nursing, Dr. Amandeep Kaur Bajwa. Ma'am, please receive the honor. Next, I call upon Dr. Karuna Sharma, Professor, Obstetrical and Gynecological Nursing, to receive the honor. Next is Ms. Ranga Naiki. I think she is not present today, but we should acknowledge her also. Next, I call upon Mr. Gopal Charan, Associate Professor, Pediatric Nursing. Sir, please. Next in the list is Miss Manmeet Kaur, Associate Professor, Pediatric Nursing. She is still busy. She is still busy as she has served you food in the last 3 days. She was organizing for the food and all things. So she's still busy there, I think.
Dr. Sukhbir Kaur, Associate Professor in Psychiatric Department. Next is Miss Rupinder Kaur, Associate Professor. Mr. Naveen Kumar, Assistant Professor. Miss Gurjeet Kaur, Assistant Professor.
Miss Gurjeet Kaur.
Miss Ujala Joshi, Assistant Professor in OBG Department. Miss Ujala Joshi. Next, Miss Akshpreet Kaur, Assistant Professor. Miss Kiran Preet Kaur, Assistant Professor. Miss Pooja Joshi, Assistant Professor. Miss Rajbir Kaur, Assistant Professor in OBG. Miss Kulwinder Kaur, Assistant Professor. Miss Manmeet Kaur, Associate Professor in Pediatrics. Now all the lecturers be kindly in the stage. Miss Amandeep Kaur Pannu. Miss Ravneet Kaur. Miss Ravneet Kaur. Miss Maninderjeet Kaur.
Miss Maninderjeet Kaur. Miss Onkardeep Kaur, OB-GYN specialized. Miss Mandeep Kaur, Medical Surgical Nursing. Miss Kamaljeet Kaur, Community Health Nursing. Miss Praveen Patrick, our Senior Nursing Tutor. Miss Amanpreet Kaur Khera, our Nursing Tutor. So give a huge round of applause for this organizing team. Miss Kamalji, Community Health Nursing. Miss Praveen Patrick. Miss Amanpreet Kaur Khera. Okay, Miss Amanpreet Kaur Khera. Give a huge round of applause for her. So the conferences or workshops can't be completed without the help of the people, those who are working behind the scene. And we will like to appreciate them also. And our own Manmohan Singh, he's a state officer. So kindly, sir. Mr. Harinder Singh from IT department. Thank you, Manmohan Singh, sir. Mr. Harinder Singh from IT department. Miss Sujata. Miss Sujata. Miss Sujata. Jasprit Singh, Mr. Jasprit Singh. Miss Navjot Kaur, Miss Navjot Kaur. Miss Pooja, Assistant Professor. Miss Navjot. Mr. Harinder. And of course, the people always on the computer, our own staff, clerical staff, Miss Manjeet Kaur, Miss Manjeet Kaur, Miss Manmeet, Miss Gagandeep,
Next, Mr. Hemant from CBSE Publisher and Mr. Gurvinder from INSCOL. Please receive a token of appreciation, Mr. Hemant and Mr. Gurvinder from INSCOL.
Mr. Gurvinder. Okay. Okay, now the person who is always clicking your smile. Mr. JP sir. The token of appreciation for him also. Now somebody has to hold the camera for him. Okay, now there is a winners for the quiz competition. I'm going to announce. Tanu. First winner is Tanu. Second is Aman. Third is Komalpreet. Fourth is Mandeep Kaur. And fifth is Nisha Kumari. Our winners are there. Tanu is not there. Aman. Komalpreet, Mandeep, and Nisha Kumari. Okay, you can collect on behalf of them. Students can collect on behalf of them and then you can hand over. Please receive the awards and you can hand over to the winners afterwards. The first winner is Tanu. Aman, second winner. Third, Komalpreet. Fourth, Mandeep Kaur. And fifth, Nisha Kumari. And for any queries, you can contact Mr. Hemant from CBS Publisher if any doubt is there. So you can contact him. Thank you, dignitaries. Kindly occupy your seats on the dais. Thank you, dignitaries.
So now we request Kunjan Kulkarni, NCI Nagpur, Head of Nursing Department, who was one among of the participants for the conference, to kindly give her feedback. Ms. Kunjan Kulkarni.
We will be giving participant feedback regarding the 3-day conference.
Thank you, ma'am. Thank you for giving me the opportunity to give feedback on behalf of the entire participants. Good afternoon to one and all, respected dais on the dignitaries, respected nursing officers, nursing faculties, students, and trainee students. Hereby, I am very thankful to give me an opportunity to express my views regarding 4th International and 20th National ONI conference, which is held at SGRD Amritsar. I firstly would like to congratulate SGRD College of Nursing to take an initiative to open a new chapter of ONI. I especially would like to thank Dr. Rupender Kaur Madam for being so kind of her heart from the day first when I called her for helping me throughout the, regarding the conference till the end of the day. I would like to thank the ONI and SGRD for providing me opportunity for paper presentation and for poster presentation of my staff from National Cancer Institute, Nagpur, Jamtha. Regarding the conference sessions, all the sessions were very informative, which helped the nursing faculties, nursing officers, staffs, and the nursing students to add on to their knowledge regarding the oncology aspects in the nursing care as well as patient care. All the arrangements and the hospitality was really very appreciable. The food was very tasty. The last night where we enjoyed a lot and which helped out to relieve our all the tiredness throughout the conferences, which was really appreciable. They were the organizing committee members of the dais, on the dais, were very soft-hearted, helping nature in every moment, which I'd like to thank to the SGRD for free accommodation facilities made available for the delegates who came outside from Punjab. Thank you all the faculty members, nursing officers, dear friends and nursing students and persons involved directly and indirectly to conduct and to make this conference a great success. Lastly, would wish to express my gratitude and also to wish to participate in the conferences and workshops which will be organized by ONI and SGRD in the forthcoming years. Thank you one and all. Thank you once again.
Thank you, ma'am. And one volunteer was there from Stephen College. He also want to share his views and give a feedback. So in 1 or 2 minutes, you can conclude or give a feedback. Rahul from Stephen College, please give a round of applause.
Good afternoon to all. Present here, I Rahul, student of MSc Nursing, and I'm from Stephen's College of Nursing, and I'm from Jammu. So I would like to say thank you to all the organizers, faculty members, and the students of SGRD University who showed their valuable interest and irrespective of day and night, and they had given their 100% will full of enthusiasm in order to ensure the comfort for the guests as well as the participants. So it was great experience to witness this ONA workshop at SGRD University. Thank you for all the organizers of this workshop planned fabulously. It was a very knowledgeable experience for all of us, and every speaker taught us in a pleasant and attractive manner. So I personally wish these type of conferences should be held again and again in order to enhance our knowledge. So the overall management of SGRD University was wonderful, and they has done a tremendous job. Thank you to all of us.
Thanks, Rahul. Now we request Dr. Manpreet Kaur, Vice Principal, SGRD College of Nursing, for vote of thanks.
So a great afternoon to each one sitting over here, and I will not take much of your time. So thanks has to be there. So thanks to Almighty God for showering his blessings throughout all these 3 days for organizing this conference. And with a deep sense of gratitude, I would like to thank our chief guest, Dr. Manjeet Singh Uppalji, for sparing his time and being with us. Our guest of honor, Dr. Anita D'Souza, Dr. Rita Lakhani. And I really appreciate, and personally even I got inspired by your wisdom, your cheerfulness, positivity, and way of sharing your knowledge and experiences. I once again thank all our Dr. A.P. Singh also, organizing chairperson, Dr. Parvez Saini, organizing co-chairperson, Ms. Rupinder Kaur, organizing secretary, for taking up this initiative to organize such a gala event. And thanks to all the keynote speakers, especially Dr. Isabella and Dr. Annie Young, all chairpersons, resource persons, who have delivered their deliberations and wonderful lectures, and especially the hands-on training was awesome. Our faculty for active participation, all the delegates, and of course students, without whose active contribution and participation in this conference, we could never even think about having these kind of events. So once again, thank you one and all, and have a great weekend and safe journey, those who have come from faraway places. Thank you.
Thank you, ma'am. And I request all of you to please stand up for national anthem. Kindly.
जय गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. Jai Hind. Thank you all for being patient, and see you in future, and hope you will again be visiting SGRD campus in our future conferences endeavors, and we wish you to see you again. Thank you all. Thank you, the dignitaries. Thank you. Thank you, sir. Thank you, the SGRD management. Sat Shri Akal to all of you.